I think that in general, but may not be true 100%, the chronic GvHD patient, the severe chronic GvHD patient, do not die from the manifestation of chronic GvHD except of high immunosuppressive therapy and maybe opportunistic infections. The big problems these patients are facing is actually the alteration of quality of life. And I think we all heard this traditional thought that, thank you, doc, you cured me from my leukemia, but now I'm struggling with another disease, and it's a nightmare, namely chronic GvHD. And when it comes to quality of life, of course, it's a difficult topic, very complex, because obviously the quality of life of a young 25-year-old gentleman is totally different or could be different from the expectations of a 70-year-old lady and so on. So there are different domains where there is an impact. The symptom burden, which is not always very well measured. We always, in our evaluations, concentrate on the physical examination, and we mentioned already, okay, we measure PFT, so it's like a very objective number, so you know where you're going. But it may be more, from a patient perspective, a little bit more subtle. Also, we should not ignore, and it was also mentioned, that we keep on accumulating immunosuppressive treatments, and all of this would lead to side effects, adverse events, but also drug-to-drug interaction. The impact of comorbidities is crucial because we're transplanting more and more older patients with comorbidities, diabetes, metabolic syndrome, history of cancer, prior history of chemotherapy, and all of this is going to add on and alter the quality of life. The prolonged use of high-dose steroids is really a drama where we're facing all the time, and until now we have failed, but I think with the advent of some new drugs in combination, we may be able to minimize the steroids exposure. And there is this issue also of the social impact of chronic GvHD in terms of losing your job, unemployment, of course, leading to low income. And this is something that is happening over the long term. And if this is happening in a young patient who is 30, you would expect that for several decades, this problem will exist. And we are sometimes, I mean, most of the time, I think we're not able to provide the right support and so on. So I wonder whether this group has some general thoughts, ideas, how we can improve this situation, because at the end of the day, it's not only about having a new drug. New drugs will not solve all the problems because, and we all see, I think, these patients complaining from dozens of things, and we are all well aware that the chronic GvHD consultation is a very long one, and it has to be multidisciplinary. We have to involve the nurses, the social workers, the psychologists, and many, of course, other specialists, like the gynecologist or the pneumologist, and so on. Someone wants to start the discussion, throw something? How do you measure in your center quality of life, for instance? Do you measure it, by the way? I would be very curious. Steve, you opened your mic.
Yeah. Well, I think it's good to put this in the context of clinical practice. versus clinical trials. And I think clinical practice is a amazing question because I don't know what people would say, but I'm not aware of really this formal assessment of quality of life being deeply ingrained. I mean, we all kind of assess this, right? You know, but formalizing, I barely have seen it outside clinical trials. I know there may be some centers that are collecting data on the least scale, but it's an amazing area of need. I would like to mention just a paper was accepted yesterday. Elaine Schumann's was spearheading this. It's been published in Lancet, accepted to Lancet Hematology about community-based advisory boards, patient advisory boards. It's a brilliant idea that we get more input firsthand, not from only from us advisory boards, but patients. And I would say it's an area of unmet need. We can just go down the list what tools they exist, but I don't think in clinical practice we're really using them in any kind of discipline way. You know, we use NIH scoring, but that's a scoring that's not. So in terms of clinical trials, well, one least scale, it's been clearly well accepted, you know, and clearly it's not covering a lot. I mean, it's not covering everything, like particular lungs or skin sclerosis, you know, that needs improvement. Pediatric outcomes, you know, it's a whole ongoing area. It's not well covered and being in development. How to do clinical trials, the early assessments, you know, you say here, lack of education on transport-related AEs. So, well, there are this CTCA PROs that FDA is increasingly asking to be implemented in early phase trials, you know, to get patients' perspective. I'll stop here.
So can I ask, we have here members from different countries, from different centers. How do you do it in your own center? Is it just, you know, having a consultation and asking the patient, are you feeling well? And if they say, okay, then it's fine. Or who wants to jump in?
I mean, I guess, at least for our part, and I also know other centers, it's a very personalized monitoring, treatment, and support that we do provide. So usually, at least in our country, since most of the physicians are in clinical practice and do not have so much time off for research, we see patients fairly regularly. And then, of course, you can compare how was this person doing 3 months ago. You can also talk about that. Nurses are a smaller staff and can basically get information or discuss issues with them in this respect. So I guess if you have a good relationship and a very constant staff members and a trusting relationship with patients, they will mention more what is of importance to them, and that of course includes a lot of areas where the quality of life is affected. And then we can basically figure out what sort of support or expert we can basically then get into the team or refer the patient to that. This, of course, is due to the fact that we don't have the capacity to routinely assess it and document quality of life, as Steven has said, outside of clinical studies. And then, of course, it is also highly dependent on the individuals, both on the physician and patient side. So it could happen if you have a lot of fluctuance among staff members, that patients will not tell others what is really important to them. So I guess one way also would be that we discussed before, that patients should get more training so that they know if I have this symptom or complaints, to mention it and something can be done against it.
Thank you, Hildegard. We have Arnon, who raised his hand first.
So I want to admit, I mean, I echo Hildegard, but we don't do it in an optimal way for me because we do it, you know, very individually, not systematically by the individual, and I would guess a lot of variabilities between physician and patient. We tend to have patient groups, you know, so, you know, involve other patients that it's successful or overcome or are a strong personality, and to involve the nurses and social worker. But I would say that this should go into the survivorship, you know, clinics. We need, as you say, multidisciplinary. We need to do it more systematically than we do it. We may need to do it more objectively with electronic surveys in which, you know, the patient can answer and the physician without, you know, inventing the wheel, or do it more objectively and maybe faster, because, you know, it's involved a lot of time, and usually the busy physician in the clinic don't have this type of time to invest. So I would say that there is a lot of way to improve in it, at least for my personal clinics in transplantation. And this is also issues that the physician, you know, knows that it's very important to the patient, but it's something that they are not investing or don't have the time or even the will to invest a lot in this area. And these are very important area for the patient.
But maybe, Arnon, if I can be provocative, couldn't this be a sort of not only a problem of time, but also due to the fact that sometimes we are helpless. We don't have anything to propose. And then usually when you are stuck, when you have no solutions, it's you just like skip it or ignore it or whatever. So, and maybe the story will change now that there are many therapeutic options to be considered. Florent, you wanted to add something to this?
You just have the point that now we have some therapeutic options, so things may change because of that. So far what we are doing, we have no very true assessment of quality of life. We are just asking people, how do you feel? And people say, yeah, I was able to go walking, biking, to do some stuff. And it correlates with the answer, with the clinical answer. So, and it's already a good way to know if the quality of life improve. And this is just for routine. This is not clinical trial. So for us, it's already some important information. Now that we have some new drugs, I think patient-reported outcome evaluation will be very important, because we know that sometimes this is difficult to evaluate fibrosis and everything to assess the answer, but patient-reported outcome could be very important just to know if the patient's answer to the treatment, if we are able to decrease the treatment, because we discuss the fact that we need to improve the treatment, but we need also one day to discuss treatment discontinuation if we have some effective treatment. And we will need a good evaluation of quality of life to be sure that the patient's answer improve before we'll be able to discuss the fact that we need to stop the treatment.
Thank you, Florent. Let me go back to this, to the patient concerns. And I think, Steve, you have mentioned this something that I'm not familiar with, the patient advisory boards. And we do have patient days in general where we provide some general information, but can you expand a little bit on this topic of patient advisory board? Who is organizing this, and what kind of discussion there?
It's a European male initiative, and it's really the idea that there are some advocacy groups here as well from the US involved. The idea is that we need more formalized regular access and input from patients about what matters to them. And so it's a really more formalized organizational network that will serve those purposes. That's proposed. It's still in the early phases. There was a pilot study that was conducted, but you know, it's an idea that's really it seems to getting traction. You know, and I don't know, Hilda, were you involved in this too? I forgot.
No, I mean, I heard about it and there were some discussions, but not, I don't know more of the details to what you already have mentioned.
So the paper has been accepted to Lancet Hematology.
Well, thank you and congratulations for.
Well, Elaine Schumas is the first author. She was the spearheading the effort.
So I see Professor Oliveri here. Attilio, you are a center of excellence for management of chronic GvHD. How do you handle this issue of quality of life and patient-reported outcome outside clinical trial?
Hi, Mohamad. Thank you for your invitation. In our center, we currently use the combination of Lee scale with a short format 36 questionnaire. And I think the combined use of these two tools can cover with satisfactory results the evaluation of quality of life of patients. Of course, we will need also more specific tools for evaluating quality of life in a particular setting, for example, pediatric patients or patients who had an active job, which should be differently evaluated from a patient who were not active in their job. But in our experience, the routine combination of Lee scale with short format questionnaire is a good combination.
Thank you very much. That's very clear that indeed these are tools that can be used more easily than what we think, and they are not so much, they're not time consuming, but obviously it's not always easy. One question I have to the group here is about, because we mentioned a lot the new drugs, and we're very happy because after like 40 or 50 years of stagnation, we have now in the last 5 years or so some a new agent, different mechanism of action. So all of this is great. The question is, how would you consider in your practice, from your perspective, when according to the NIH criteria, you have like stable disease, assuming not really a wow effect on the activity of this or this drug, but the patient telling you clearly, oh, I'm feeling better, I don't think it's a rare scenario, especially for those patients who have been receiving, many lines of drugs. Attilio, can you comment on this?
To my opinion, it's a very good point, because it's not a rare scenario, because in many cases we are able to evaluate a better situation according to the patient-reported outcomes, but we cannot classify this outcome as a partial response according to the classical NIH criteria. I completely agree.
Any thought? Would you agree that in a trial, for instance, where we see the magnitude of response not huge, but clearly an improvement of the patient well-being, you would be satisfied with such outcome?
Well, another aspect that has been discussed several times is the ability to reduce in a relevant percentage the steroid use. Also, this criterion is not, of course, an NIH criterion, but according to the evaluation of quality of life for this patient, to my opinion, is very important.
Thank you very much, Attilio, and thank you all for sharing your perspective and thoughts on this issue of quality of life, which I think is incredibly important. And thanks to all the novel approaches, I think we will be able to continue to improve the quality of life. Ideally, we would love to prevent and eradicate chronic GvHD, but in the meantime, we have to live with it. And I think more and more, we should not neglect the importance of the multidisciplinary approach, because it definitely, I think, help the patient. It's not about only the transplanter or the hematologist prescribing this or this drug. It's all about this team effort from the, I think, the medical team who perform the transplant, whether the specialists and nurses, the pharmacists, the psychologists, physical therapy, but also outside. I think when the patient would feel supported thanks to the support group, when the patient feel to be informed about the advances of science, actually bringing hope and optimism can by itself, I think, help these patients to cope with the burden of the disease. So thank you all. I think we had a really lovely discussion.